This is the lecture for adult in-hospital cardiac arrest, which will include the universal algorithm involving shockable rhythm and non-shockable rhythm. Now, sudden cardiac arrest occurs when the heart suddenly stops beating normally, and this is usually due to two main causes. Firstly, an abnormal arrhythmia, primarily VF or pulseless VT, where the arrhythmia prevents the heart from beating. Or secondly, any abnormality preventing the mechanical pumping of the heart. For example, intention pneumothorax, cardiac tamponade, hyperkalemia, or so on. Now, when the heart suddenly stops beating, within seconds, the circulation stops, and therefore, the patient will collapse. Sometimes, at this stage, they develop a brief seizure, and very often, the breathing pattern changes to a breathing pattern called agonal breathing. A sudden collapse, followed by a seizure and agonal breathing, is a sign of early cardiac arrest, and we have to be on the lookout for these signs if we want to recognize cardiac arrest early. If nothing is done within minutes due to the lack of blood flow to the brain and the vital organs, irreversible brain damage and damage to the heart itself will start occurring. And approximately by 10 minutes to 12 minutes, without any assistance, the brain will be dead and the heart will be dead as well. Resuscitation carried out after this usually has very poor prognosis and never complete neurological recovery. So survival outcomes after in-hospital cardiac arrest is generally poor unless a few characteristics are done, a few key points are achieved. Firstly, if you can identify that a patient is deteriorating before they go into cardiac arrest and they are treated at that time when they have not gone into cardiac arrest, they're still deteriorating, it is so much easier, so much more effective, and so much better recovery if we can treat them before they go into cardiac arrest. If they have already gone into cardiac arrest, if that cardiac arrest is noted early on by bystanders, family members, or healthcare workers, so that immediate treatment can be provided. Very often, unfortunately, this is not done, and the cardiac arrest is only recognized after many minutes have occurred. Survival is poor unless immediate bystander CPR or CPR is performed by healthcare providers. If we have a shockable rhythm or rapidly reversible causes, then survival outcomes will improve. And in the shockable rhythm, early defibrillation with an AED or when a defibrillator is available. Recent studies have showed us that not just CPR but high quality CPR is associated with good outcomes and especially good neurologically intact outcome, meaning that the brain is still fully functional and the patient can return to normal life. If the patient has a reversible cause that we can identify and treat, remember some of the 4 H's and the 4 T's. And especially if the patient can achieve ROSC, a return of spontaneous circulation, and so that we can initiate early definitive post-resuscitation care. So the role of the healthcare provider are these and these only. We have to diagnose early the deteriorating patient before they collapse if we can. If they collapse, we have to activate the code blue team and perform initial resuscitation measures very quickly. If the patient is in a shockable rhythm, we have to analyze and shock and defibrillate the patient as soon as possible. We have to make sure that the CPR that we perform is continuous and of high quality. Wherever possible, we have to identify reversible causes and consider other measures so that the patient gets the best care that we can offer. And if the patient achieves ROSC, we have to prepare for very aggressive and complete post-resuscitation care. Now, identify cardiac arrest early, especially in-hospital cardiac arrest, is not very easy. Very often, these patients are on a vital sign monitor, but staff very often do not diagnose that they are in cardiac arrest until after several minutes have passed. So it's important to suspect cardiac arrest when we get abnormal or we're not able to obtain vital signs, when the monitor shows sudden severe bradycardia that's getting worse, or the monitor gets you an SpO2 reading that's not displaying and cannot see the waveform, and especially if the SpO2 is deteriorating, and or the cardiac monitor shows you slow and white complexes. These are important to recognize that if you see these signs, we have to check for a pulse. And if the pulse is not clearly felt, then this patient is in cardiac arrest and we have to start chest compressions. The signs that we have to look out for in particularly as agonal breathing, or sometimes called gasping. In the local language, we call this nyawa ikan. Very often patients develop a brief generalized seizure, and this is often misdiagnosed as epilepsy or seizure due to other causes. So any patient that develops seizure and unconsciousness suddenly and unexpectedly, we must think of cardiac arrest and feel for a pulse immediately after the seizure has stopped. Any patient that develops sudden unconsciousness or suddenly fainted, again, cardiac arrest is something that we must consider. And we have to look for absence of normal breathing and or feel for a pulse. So if we identify that this patient may be in cardiac arrest, then immediately, simultaneously, a few actions must move. First thing, we must check for a definite pulse. As we feel the pulse over the carotid area, we must definitely feel a pulse. If we are not sure or cannot feel a definite pulse, then we must start chest compressions. And as we start chest compressions, we must shout for help to activate the emergency response mechanism. And the responders that come must bring a few things. Firstly, they must respond quickly, bring the defibrillator or the AED. They must facilitate chest compressions by helping the compressor to perform it better, by putting the bed down to a low level, bringing the bed railings down so that they have good access to the patient, bringing the head down so that the patient is supine completely, and bringing a stool so that chest compressions can be performed much better. Shortly, this is called bed down, head down, railing down, stool. We must bring the resuscitation trolley because further actions use the resuscitation trolley. Head down, bed down, railings down, stool. So this is part of the initial resuscitation measures in the patient with sudden cardiac arrest. Immediately after starting chest compressions and getting the resuscitation trolley and the defibrillator, the first priority will be now to identify a shockable rhythm. And when we identify a shockable rhythm, we put on the monitor and look for the two shockable rhythms that we can recognize, which are VF or pulseless VT. And if the patient has a shockable rhythm, then as soon as we can, we should deliver the first shock. A shock should be delivered in a patient with a shockable rhythm. A shock should be delivered every 2 minutes, and in between, the high quality CPR is continued with minimal interruptions. We should use this time to give oxygen, get IV or IO access, attach ECG monitoring, and we should give adrenaline a bit later, every 3 to 5 minutes. All this time, the team leader should consider the potential for reversible causes, and if we get the patient back for post-resuscitation care. High quality CPR in revision means that chest compressions must be continuous of 100 to 120 beats per minute, 5 to 6 centimeters of depth. We must minimize chest interruptions to chest compression, meaning that chest compression fraction must be more than 80% of the time, which means that more than 80% of the time, the compressions are going on with very, very little interruptions, none if possible. We must allow for full chest recall because chest recall means allows for blood to return to the heart so that the next compression is full of blood and can improve the circulation. We must change our compressor every 2 minutes because otherwise they get tired and they will not allow for full chest recoil and the depth will not be insufficient. We must minimize peri-shock pauses to less than 5 seconds to ensure the efficiency of each shock. We must avoid excessive ventilation at 10 breaths per minute only, enough just to see visible chest rise. We must use capnographic waveform monitoring to help us identify high quality CPR, help us identify return of ROSC, and prognosticate on the outcome of the patient. And it's useful to use current technology with CPR feedback to help us perform CPR better. So what are our priorities if we identify a shockable rhythm within the first minute or so? Firstly, high quality CPR on a monitor, and we can attach the end-tidal carbon dioxide monitoring where we can. If we see a shockable rhythm, then the patient must be defibrillated immediately and then again every 2 minutes. Somewhere along this line, we have to give adrenaline 1 milligram every 2 cycles or 3 to 5 minutes. And after 3 shocks, if the patient has not reverted, then we have to give amiodarone 300 milligrams, which can be repeated with 150 milligrams after. We must always consider reversible causes of shock. Reversible causes of shockable rhythm, and we must always try to identify ROSC when it occurs. Post-resuscitation care is particularly important and shows very good outcome, especially the actions of hypothermia and early PCI, especially in shockable rhythm. If the patient has non-shockable rhythm, then the priorities are to perform high-quality CPR, monitor the patient with end-tidal carbon dioxide, identify there's a PA or asystole, give adrenaline 1 milligram every 3 to 5 minutes, and then in step by step consider all the reversible causes and treat any identified ones. Must identify ROSC again post-resuscitation care if we can get them back. This is a universal algorithm for cardiac arrest in hospital. The first priority, identify a shockable rhythm, then look for the reversible causes in airway and breathing, reversible causes in structural, reversible causes which are metabolic, and the other interventions which may help. All this time to continue the middle high quality CPR continuously with all the actions that are written there. After the first priority, which is to identify whether there's a shockable rhythm or not, and if there's a shockable rhythm, to give the first shock. Then the next priority is to identify, is the airway clear? And to do this, there are various step-by-step actions that we must do. Firstly, we have to put up the oropharyngeal airway, connect the back valve mask to an oxygen source, and provide single breath ventilations in sequence with the CPR. So at this stage, it's usually 30 compressions to 2 breaths. We're aiming at visible chest rise, and what we're looking at is no sounds coming from the airway. If we have visible chest rise and no sounds coming from the airway, this means that the airway is clear. If, however, if you have sounds and you cannot see visible chest rise, then it's necessary to perform suctioning to remove any potential secretions of foreign body from the airway, and reposition the airway, and then retry once more. However, if after suctioning and repositioning there is still no visible chest rise, or there's still persistent sounds from the airway, then it's time to consider that we have to provide a definite airway. At this stage, we should consider the potential for difficult airway now. I will refer you to the difficult airway table in the book. A definitive airway at this point would preferably use a laryngeal mask airway or a supraglottic airway, because in the cardiac arrest patients, we have to quickly put in an airway and not risk too much time of an endotracheal tube. Putting up an airway is covered in the airway lecture and covered in the chapter on airway. Once an airway is inserted, then we continue to provide positive pressure ventilation with PEEP and on O2 supplementation. It is useful at this point to connect this patient to waveform capnographic monitoring to identify airway integrity, and also to help us identify high quality CPR. The next thing to consider is to use an ultrasound to rapidly identify structural reversible causes. And to do this, we use a focused abdominal cardiac ultrasound, looking for particularly number 1, evidences of hypovolemia, by identifying IVC diameter variability. This is looking for hypovolemia, one of the H. We also look in the lungs for signs of loss of the sliding sign, which may indicate presence of tension pneumothorax. That's T. We look for pericardial collection around the heart and evidence of right ventricular collapse, and that indicates cardiac tamponade, another T. We may at the same time look for dilated right ventricle and shape of the D shape of the left ventricle that indicates pulmonary embolism. That's another T. We may see hypokinetic cardiac segments or hypodynamic left ventricle, which may indicate severe myocardial ischemia. That's another T. Ultimately, we may identify that the patient has cardiac standstill and total absence of cardiac activity, which tells us that prognostically the survival is very unlikely, and the likelihood of calling off cardiac resuscitation, CPR resuscitation is high. Going on from here, we now would like to take blood samples to identify potential metabolic reversible causes. High among these are changes with potassium, especially hyperkalemia, which we identify with ABG reading. Now, hyperkalemia is very common seen in ESRF, end-stage renal failure, in sepsis when there's massive tissue damage from crush injury or burns or post-chemo. Hypokalemia may also cause cardiac arrhythmias, and we must look out for that, especially if the patient is bradycardic and showing signs. Especially if the patient is on digoxin medication. TCA overdoses, although less common these days, can be identified by very wide ECG changes, wide QRS seen on ECG changes. Hyperthermia is seen only in exertional conditions in laborers or people running extreme sports, in environmental situations where it's a heat wave, or sometimes in rigorous army training. And interestingly, more and more these days, in patients who use lifestyle drugs like ecstasy and other recreational drugs. And we can identify this by temperature monitoring and also by identifying some changes on the ABG. We can identify opiate overdoses by identifying hypoventilation, hypoxia on ABG, and identifying respiratory rate. This is again a H, a T, a H, and a T. And you will recognize that by looking for structural metabolic causes, we can actually identify all the H's and all the T's. The other interventions that we may consider at this point are mechanical CPR devices, especially when prolonged CPR is needed. And that gives us time to treat reversible causes like the H's and the T's, and it also gives us time if you're planning for further invasive interventions. Example, if the patient is ideal for PCI or going for ECMO and so on. In a patient that has post-resuscitation care, PCI must be considered, but in some centers, PCI may be done in patients who are undergoing CPR. That's not particularly common. In the future, we probably may put up ECMO situations, and that's called extracorporeal life support. Or in some situations, there may be need for surgical control of bleeding, which may have led to cardiac arrest, especially in ectopic pregnancy or upper GI bleeds. If the patient has ROSC, which means return of spontaneous circulation, that means that the normal electrical and mechanical heart activity has come back. And that's seen when on ECG we notice organized rhythm, which means we can see now narrow, irregular QRS complexes. The pulse becomes palpable at the peripheries, where you feel pulses at the radial pulse and at the carotids. That usually indicates that the systolic blood pressure is more than 90 mm mercury. The end tidal suddenly spikes more than 35 mm mercury from before. SpO2 waveform starts becoming more clear, and SpO2 readings become going to normal. And obviously, when the circulation returns, the color will improve. The patient may start coughing or moving or breathing. All these are indicators of ROSC. However, it is very good that the patient has return of spontaneous circulation, but they are still at risk for recurrence of cardiac arrest. They're still at risk for multiple organ failure, and they're definitely at risk for reperfusion injuries. And therefore, it is not time to stop being aggressive. It is, in fact, time to move on to aggressive post-resuscitation care. So post-resuscitation care are key measures must be instituted to improve neurologically intact survival to hospital discharge. Now this is the key word, improving neurologically intact survival. This means that the patient continues to live but remain the neurological function, the brain function remains intact. So they are independent, they can take care of themselves, they can be fully functional, and they can return to normal life. And that's most important. It is not anyone's intention to have a patient live but in a persistent vegetative state or in a state where they need full-time care. So post-resuscitation care is very, very important to make sure that the patients get the full potential of neurologically intact survival. In the immediate post-resus phase, a bundle of actions have to be done, and to make sure that the start of post-resuscitation care is as aggressive as resuscitation itself. It's important to maintain adequate oxygenation and ventilation, and we're going to use the SpO2 to monitor this. So SpO2 should be 94 to 98%, never 100%, never 100%. It cannot be 100% because too much oxygen is bad, and it cannot be below 94% because too little oxygen is dangerous. So keep it between 94 to 98%. Keep the PaCO2 around 35 because too low will affect brain function and too high will affect overall hemodynamics. We must try to maintain normal hemodynamics with fluids first, and if not sufficiently with pressures. It's important to make sure that circulation returns as much to normal as possible. Aggressive glycemic control with glucose less than 10 millimole per liter must be the target, using insulin injections to control it if it goes too high. We have to identify that the cardiac arrest may have been due to acute coronary syndrome, which is a very common cause by the ECG, and if that is so, then the potential for early PCI improves outcome markedly, especially in VF cardiac arrest. In some patients, they may be selected for targeted temperature management, where the temperature is brought down to a low level to preserve neurological function. All patients will require seizure prophylaxis if structural brain injury is suspected, because any seizure will worsen brain injury. And many patients, we should consider antiarrhythmics in some patients, especially if they are showing ventricular ectopics. Targeted temperature management is strict control of core body temperature to a temperature below 36, and this reduces reperfusion injuries and improves neurological outcomes. Now, how do we do this? Now, it's important to monitor these patients using a proper temperature probe, and the best is an esophageal temperature probe. In the post-ROSC period, immediate cooling is done with cool normal saline, 4-degree fridge temperature normal saline, or the use of specific cooling devices. Initiated very soon after ROSC, this should be continued in ICU for at least 48 to 72 hours. Emergency PCI is very, very useful to reperfuse ischemic part of hearts, and is associated with long-term survival and high neurologic intact survival. It improves myocardial function immediately and reduces risk of further dangerous arrhythmias. In particular, this is very useful in shockable VF and VT presenting rhythms, or in patients with recurrent dangerous arrhythmias or frequent ectopics. It is particularly useful as well in patients with very poor cardiac function or high KINEP scores, because otherwise these patients invariably will die from a second cardiac arrest incident just a bit later. So the role of a healthcare provider, in summary, is to diagnose early the deteriorating patient before they collapse, activate the active code blue team immediately when you identify collapse, perform initial resuscitation measures. The first priority is always to analyze and shock when a defibrillator is available. High quality CPR must always be performed. The potential reversible causes must be identified, looking at the airway, the structural abnormalities, and the metabolic abnormalities. We must consider other tools to help us resuscitate better, and when we can, prepare for a very aggressive post-resuscitation care. That's all for a universal algorithm of adult in-hospital cardiac arrest. Thank you.